All right, we are going to kick the afternoon off with a panel of cases. We have a dynamic group of sports medicine providers who are going to talk and debate a few cases, and I would like to first introduce them. So, all right, let's see if I can find, okay. So first, Hannah Oyedeji is a certified athletic trainer with UCSF Sports Medicine. She earned her Bachelor of Science in Athletic Training from Boston University in 2019. She joined UCSF Sports Medicine in 2022 and has been the head athletic trainer at Urban High School, where she's been instrumental in advancing injury prevention, functional movement training, and concussion education within the athletic community at Urban. Hannah also works side by side with us in sports medicine clinic at the UCSF Orthopaedic Institute. And her favorite part of this is teaching McConnell taping McConnell taping to all of my patients. I might have made that up. Next up is Nina Freitas. Nina is a UCSF physical therapist who was an undergrad at UCLA, go Bruins, and did PT school at Mass General. She's an amazing sports PT who also has expertise in sports concussion. She's also a clinician in our UCSF Women's Sports Medicine Center, as well as the physical therapist for the Oakland Roots. She has experience both in the clinic and on the sideline, and I'm really excited to hear her perspective on these clinical cases. Welcome, Nina. Next up is Cindy Chang. Dr. Chang is a primary care sports medicine physician who's a UCSF professor emerita in our Division of Primary Care Sports Medicine. She's the founder of our UCSF Primary Care Sports Medicine Fellowship and is a key mentor for our fellow and our faculty. She's chief medical officer for the National Women's Soccer League. She's a team physician for U.S. Rowing, and she's past president of the American Medical Society for Sports Medicine. Dr. Chang's on a variety of committees, both locally and nationally, to improve the physical and mental health of athletes at all levels, and she's the perfect person to join this panel and bring her expertise to our challenging cases in sports medicine. And lastly, I'll introduce Dr. Michael Davies. So Dr. Michael Davies is an assistant professor in the UCSF Department of Orthopedic Surgery who specializes in sports medicine and shoulder surgery. Dr. Davies was a UCSF medical student and orthopedic surgery resident. He did fellowship in sports medicine and shoulder surgery at the Hospital for Special Surgery in New York. We're fortunate that Dr. Davies returned to join our team at UCSF Sports. He cares for patients both at the UCSF Orthopedic Institute as well as Zuckerberg San Francisco General Hospital. He's currently our team doctor at Lincoln High School and is also an accomplished researcher focusing on the role of stem cells in tissue regeneration. So from here, I'll turn it over to the panel and welcome Dr. Chang to the podium. Please welcome our speakers.
Thank you, Dr. Center, for that kind introduction. All right, these are my disclosures. None of them reflect the organizations with whom I belong. Here's our history and physical exam. 13-year-old high school student presented to the ED in mid-July, worsening upper left abdominal pain, had been swimming in a mountain lake for the past 3 days, has sickle cell disease since the age of 5, but has not needed hospitalizations and no blood transfusions. On physical exam, was afebrile, was tender palpation in the left upper quadrant with spleen tip palpable 4 centimeters below the rib cage, the costal margin, at the level of the umbilicus. And for those of you, just a quick review, labs and imaging. Hemoglobin was 8.6. His baseline, the last time it was drawn, was 10.8, so greater than 2 gram per deciliter drop. Platelets were low at 74,000. Retic count, a measurement of immature red blood cells, was 0.159. You can see the normal range there. And the hemoglobin electrophoresis was 49% HBS, 42% HBC, and 3.6% HBA. So ponder that. Ultrasound imaging had splenomegaly, 18 centimeters. Normal is less than 12. And no identifiable vascularity compatible with a splenic infarct. I will say that a lot of the guidelines in terms of, when we do PFTs, when we have imaging norms, et cetera, is usually based on a largely demographic of Caucasians, right? I mean, if you think about how some of these numbers were done, and African American, actually, Americans have a smaller spleen size normative relative to, for example, Caucasians, and this is independent of body size. So just kind of keep that in mind when you're looking at norms. So the diagnosis was acute splenic sequestration crisis, for which he was admitted, IV fluids, morphine for pain. And during the hospital course, the spleen remained enlarged, everything else improved, and he basically announced that he wants to play high school football, and therefore he wants his spleen removed. So the question here is, what is not a potential risk of a splenectomy? The first, you think, what? You want your spleen removed? What does a spleen do? So what is not a potential risk of a splenectomy? And I don't believe it's this on HWOVA, but it is. Holy macaroni, technology. Okay, do I go forward to see this? Or do you guys do something in the back room there? I don't see any votes yet. If you don't know, just guess. It doesn't matter. We don't know. It's anonymized. This is the beauty of it. It's anonymized, everyone.
Okay, the votes are coming in.
Votes are coming in.
We've got 13.
Survey says. Ha. This is awesome. Okay, well, the correct answer is low white blood count. All right, do I go back? Do you guys go back? Okay, so the goal here is shared decision-making, right? I mean, in the end, we'll talk about this briefly, but when we talk about the pros and cons, risks and benefits of having any type of injection, intervention, procedure, and even medication management, you have to talk to your patients about this, like risks, what are the side effects, et cetera. This is all shared decision-making. So the goal is, and you guys all know this, but it's only recently entered into sports medicine. It used to be very patriarchal in terms of this is, no, you can't, you're not clear to participate. And now it's definitely leaned towards more, let's talk about this. So so something's going on with this talk.
Oh, because it switched to speaker.
I thought this was all out of order. So my talks didn't load. The slides didn't load properly. Do what again?
I'll check up in the box again, or if you have it somewhere on a thumb drive, you can load it real quick.
Okay, so what we're going to do is jump to the next case, because this is throwing me off a bit. I'm going to check with you, and let's just jump to the next case, okay? Because there's something wrong. This working? Perfect. Okay, so while we get this hooked up, so we talk about the quadrants of the abdomen, and it's really important to know kind of the internal organs and where everything's located, right? So you've got that left upper quadrant, and your spleen is under there, and it should be protected by the rib cage. And then you have your liver of your right upper quadrant, and it should be protected by the rib cage. And it's similar with your, kidneys, right? When you think about trauma, sports-related stuff. So important to know that if that spleen is exposed and this young man wants to play football, then the question is, if he ruptures his spleen, what's the danger there? So he's saying, if my spleen remains enlarged, my whole goal is to, oh God, hang on. Hang on, let me get to my talk as opposed to what's currently showing on my screen, which is funny. Okay, are we ready to presenter view? Oh, sweet. All right, let's see how this works. This still works? Okay, that's not showing up, but that's okay. I've got it. Oh, I'll just do this. Perfect, okay. All right, so you kind of can see what sits there, right? So the protection, so essentially he's saying, if my spleen's gonna stay exposed, I would definitely want to get it removed, right? So these were the labs, we already went through that. When you look at this, so the upper right is the HBB, the beta globin on that hemoglobin, right? That's normal. And people that have HBA, they have two of these genes, right? This is the gene that, for the genotype, which is normal there. Someone that's got hemoglobin AS, which is sickle cell trait, a normal right? An A globin versus along with the sickle. So what happens is there's a substitution, and with that substitution causes the sickle, the valine instead of the glutamine, and you end up getting a hemoglobin that is actually has that sickling polymerization, right? It polymers, it sickles in certain conditions. For example, hypoxia. And so that is the sickle cell trait, which we treat these athletes like every other athlete, they can do any activity they want. When you have a hemoglobin C, okay, so the top part is sickle cell anemia, SCA, that's what sickle cell anemia. You've got two valines. This is your sickle cell anemia, are those patients that have crises a lot. It's really debilitating disease for most people that have sickle cell anemia. There's some wonderful genetic type of now interventions that are happening, but essentially we don't see a lot of patients with sickle cell anemia in contact sports or high-level competitive sports. And then someone that has hemoglobin SC. C is a different type of hemoglobin, but hemoglobin SC, you can see that there's a lysine. So it's a little bit different type of transfer that happens. It is theoretically a lesser issue having this type of sickle cell disease than sickle cell anemia, but it's variable. It certainly is a variable, and you can have as many crises or you can have minimal crises. So I don't know, but question, has anyone had a patient that's had sickle cell hemoglobin SC? Right. Okay. That's why this is a great case. Okay. So, and you can see here, this is, we love drawing these out, but this is certainly how someone can have a trait versus hemoglobin SC and hemoglobin C. So in this case, the spleen, this is an example of a splenic infarct, which is, you can see this wedge-shaped hypoechoic area up there where the arrow is, but he didn't have any indication of that on his ultrasound. Yes, thank you. All right, so again, we already went through this, we already did this. Majority of you guys didn't get this right, but it's okay. This is the learning part. And then shared decision-making. Would you recommend a splenectomy so that he could play high school football? How many say yes? Let's talk to the panel. Panel, we have an athletic trainer, physical therapist, and an orthopedic surgeon, all who cover sports. They're coming to you for trusted advice because they love you guys.
You want to start? Yeah, I'll start. So in this case, I would probably not recommend it just because I don't have a lot of background in spleen or sickle cell. I feel like I would get the symptomatic athlete and then I would refer.
Similarly, I also don't have spleen knowledge / experience, and I'm not a surgeon. But, having knowledge that they have sickle cell, if this was a patient that was coming into PT, what we would want to do is be looking at their exercise intolerance and using like an RPE scale and evaluating what their response was to exercise. And I think that's a good baseline of, they just had a hospital course. We all know how quickly you get deconditioned after a hospital stay. So the first part would be looking at what happens when we just escalate them cardiovascularly, and then it's a shared decision-making process with their rheumatologists and their sports medicine provider and their surgeons, et cetera, and go from there.
Yeah, so as an orthopedic surgeon, I also don't perform splenectomies. I leave that to the general surgeons. But I will say, what Nina highlighted is absolutely correct, which is this is really, a shared decision-making based discussion. So there, as this question highlights, there are real medical implications to being, asplenic, essentially, not having your spleen. And those include, increased risk of infection to certain bugs in particular, everything up here except for low white blood cell count. And these are lifelong implications, So I think it's important to really discuss with this young athlete what their ultimate goals are, as they relate to sport and what can be accomplished, with and without undergoing this pretty drastic surgery. And it's not something that, I would recommend for, certainly your average high school football player.
And I don't know either. So I consulted a hematologist, right? He had a hematologist, hadn't seen a hematologist for a while, but you have to involve the members of the team, know your scope of practice, know what you feel comfortable with, and we involved other members of the team. So I'm looking at these risks of a splenectomy, right? But then I started looking at the latest literature because you know what? That was my first patient with hemoglobin SC. I had never seen it before, which is why I love medicine, right? We're always learning. So this is the shared decision-making slide that you had seen earlier. This is really, really important. And in the end, I wanted to put this chart up. So this is really important. This is the differences between sickle cell trait, hemoglobin SC, and sickle cell anemia. So you look in here, the crises is much lower for hemoglobin SC than for sickle cell anemia, like 50%, half of it. Splenomegaly, you're going to have 50% by adulthood, but in sickle cell anemia, what happens, right? An autosplenectomy happens in sickle cell anemia. So you usually don't have that issue in someone with sickle cell anemia, but they have a lot more morbidity with sickle cell anemia. And exercise, you can read that as well. But for athletics participation, you can see here 4 reported cases in the NCAA, only 4. I never had any at Cal when I was a head team physician there. But sickle cell anemia rarely compete, and life expectancy, sickle cell trait, everything for sickle cell trait. We have Division I athletes, we have elite professional athletes. In the NWSL, we do too as well. But in hemoglobin SC, the life expectancy is lower than average, and then certainly in sickle cell anemia. And again, those numbers are changing. Talk about that. And then, so follow-up. So after shared decision-making, he started the meningococcal B vaccination series, again, right, to reduce the risk of infection, because after you have your spleen taken out, these are the issues. At discharge, he was stable, but his spleen size remained enlarged. 1 month, he went through a elective splenectomy. It was done laparoscopically. At 1 month post-op, he was cleared to play football. And then we educated everyone on this young man. And actually, Michael said an average high school football player, I would say he wasn't average. He'd never played football before either, right? And you're like, this young man who was small size wasn't going to be playing football at a higher level either. It wasn't like he was going to try to play in college as well. But in the end, it ended up being a family decision, et cetera, with the providers and the surgeons. And we had an agreement letter signed by the patient, parent, school administrator. This is at a high school level. So here's some educational materials. This is really important. This is all on your slide deck. But we followed the NATA, the National Athletic Trainers Association, and the NCAA guidelines for conditioning for all athletes. All athletes should have this because you don't know who has sickle cell trait. You don't know who has hemoglobin SC if they have a mild form of it, right? So everyone has to follow this because we don't want training till you puke type of drills, which happens. It still happens, especially with the old school coaches, right? Run, run, run. You're not running hard enough. Keep running, et cetera. That is what's going to lead to problems with those with sickle cell trait and sickle cell disease. These were the recommendations. The only thing I would say that was really unique for someone that has hemoglobin SC disease is teaching parents, it says coaching staff too, how to palpate for the spleen. I mean, that's in some of the literature, but But again, if it's large, it varies. Do you allow them to have a contact sport? That could be for someone who's elected not to have a splenectomy, but really wants to play a contact sport. And 6 weeks later, he played in the last JV game of the season. So basically waited, got him back in, got him in shape, physical fitness. Several months later, again in the spring, attended church camp at a mountainous elevation, and again experienced an acute pain crisis that resolved with ibuprofen, opiates, and oral hydration. And the following fall football season, he did not miss any practices or games for medical reasons, but he himself elected to sit out. This is the high heat year. He decided that he was going to sit out because he didn't want to risk having a crisis. So take home points. These are all different disease types, and they should not be considered similar. Just go back and look at that chart. However, all of them, including sickle cell trait, are life-threatening conditions, and complications can occur in each of these. So it's really, really important to understand that. Exercise should be encouraged for all, with required education, however, and relative supervision to ensure safe athletic participation for all of these groups of individuals through the lifespan. And those, especially those with sickle cell anemia, activities should be regular so that they're regularly conditioned for activity, and slowly progressive with self-monitoring of exertion level. You don't want them to overexert, right? You don't want someone to all of a sudden think that they're gonna do a Tough Mudder because their friends are doing it, right? You have to be careful about that. And individual rather than team sports are preferred. And why would you say that? Why is that a recommendation to anyone on our panel? Why did I add that? Individual rather than team sports preferred?
Yeah, I mean, I heard it in the audience first, but that's going to be more by definition a non-contact sport that could reduce risk of splenic rupture.
So what about cross country? What about track and field? What about, I'm thinking of others, swimming, et cetera. Why then, even if we include that, why would individual rather than team sports be preferred in that population?
I would say it's because, at least with individual sports, our athletes will challenge themselves based off their own numbers, right? So with team sports like basketball, you see like your other teammates like running super fast or trying to push themselves a little bit harder than they are, and so they will try to feel like I have to step up to that and push themselves. Whereas in individual sports, you don't have to do that, right? I always tell my athletes, you're just trying to beat yourself from the day before, right? Not anybody else, or you also don't even know when other people started their sport. So you trying to compare yourself to other athletes is not really helpful.
And if you went to Dr. Pandia's talk, it is certainly that, right? If you're playing a pickup basketball game and you're tired with your buddies, you'll just sit out. But if you have a coach on a team sport driving that practice or saying, come on, there's no one gonna wimp out on this drill, let's do it. That's exactly what Hannah said. Okay, I think because of time, we're gonna go to the next case. And then we'll get questions then at the end. We definitely have time for questions, but I'd like to get through the cases. Okay, thanks. No, it's okay. It's okay. It's okay.
Oh, great. All right, so we'll move on to our second case here. This also involves a young football player. So this was a 17-year-old male running back, high school football player who sustained a right knee injury while playing football, during which time he collided with an opponent and felt his knee hyperextend. He was unable to continue playing and had to be carried off the field. He had visible deformity of his knee and was not able to put any weight through his knee. His sort of sideline physical exam showed marked swelling of the right knee. He was sensory intact distally and was able to fire all of his muscle groups distally and did have palpable pulses. He was taken to the ER given the visible deformity of his knee and his inability to ambulate. And So this is not a radiology conference, but I was hoping someone in our audience here might be able to just comment on what they see on these x-rays here. Anyone? I'll give you a hint, it's a knee. Yes, so, we can't see ligaments on the x-ray, but we do know that in terms of how that joint is aligned, something doesn't look quite right. I absolutely agree. And so what we really see here is lateral subluxation of the tibia relative to the femur. So this is not a concentrically reduced joint. In other words, this is basically a knee dislocation. Even though there's not gross separation between the tibia and the femur there, when you see this, incongruent of a joint, you really have to worry about a knee dislocation. And so that's kind of what we're getting at here. So this is a knee dislocation, and by definition, in order to dislocate your knee, you need to injure multiple of the major ligaments within the knee joint. And so I did also want to just kind of pull the group here. What are some immediate next steps in management? So now this patient is in the ER, but they could still be on the sideline or on the field if you have, x-ray available at your athletic facility. So what are you going to do next with this patient in terms of evaluation and management? Great. Yeah. So in terms of physical exam, and what are sort of the most urgent things that you're looking for or really worried about in this acute setting with, we'll say, a knee dislocation? Exactly, yeah. So it really comes down to the neurovascular status, particularly, the vascular status, because these types of, multiligamentous knee injuries are associated with a very high rate of vascular and nerve injury. And so one very important exam maneuver to perform in the acute setting on these patients with these types of injuries is the ankle brachial index. So I'm not sure, if folks are familiar with that here, but that's basically just, you take your blood pressure cuff and you measure essentially the, wait for kind of return of pulse at the ankle compared to at the level of the wrist with the blood pressure cuff around the arm. You calculate your pressure, ratio there, and basically what you're looking is something that is above 0.9 or so. And if you're less than 0.9 for your ankle brachial index, you certainly have to be worried about some degree of vascular injury associated with these. So this patient got an urgent MRI given concern for multiligamentous knee injury, and I will just comment that by this point the knee is concentrically reduced, so that was able to be done closed in the operating room. And what we see here, so the first two sequences here are some sagittal views of the knee, and you can see that there's a mid-substance rupture of the PCL, a mid-substance rupture of the ACL, and then a proximal rupture of the MCL as well. So as we suspected, this involves 3 out of the 4 major ligaments in the knee. The posterior lateral corner, including the LCL, had some signal but looked okay overall. And then there was also, a tear that was noticed of the lateral meniscus. And so again, so this is clearly a very severe knee injury. This is not just, your average ACL tear in a cutting, pivoting athlete. And so I just wanted to get the group's sense on what do you think, so this is a return to play panel, but what do you think this athlete's overall chances even are of getting back to any level of play? Anyone have any thoughts? This is not a, yes?
This is crazy, but we had something similar where I've worked before, and we had like a similar injury with an elite athlete that I worked with, and it took 18 months, but they were back to full participation. Obviously, I think it's going to be different based on the level of competition for the athlete that you're working with, but it's not impossible, I guess. Volleyball.
Yeah, that's a great example, and certainly compared to our typical, single ligament return to play timeline, these, multiligamentous knee injuries can take quite a bit longer. And then anyone just want to hazard a guess what % of athletes can come back? And let's say, in this case, young athletes, because this is a 17-year-old kid. Over any period of time, getting back to sport, yeah. Yeah, I heard 20%. 60%? Okay, I hear 60.
How conscientious they want on
Right.
returning back to sport.
Right.
They may not want to after that.
Right. And this really gets at kind of the key points that I wanted to discuss here, which is that, these are sort of a heterogeneous group of injuries here. So one multiligamentous knee injury can look very different than another, especially if there's a nerve injury involvement, if certain injuries are or aren't involved, and then also, as you highlighted, the level of athletic participation. So these also aren't the most common injuries. So there aren't a ton of studies out there looking at how players do after this. But here's one study that I wanted to highlight, just looking at NFL players who had multiligamentous knee injuries, a cohort of 50 of them, whose overall return to play was 64%. And one thing that this study did point out is that which ligaments you injured does really have a bearing on how well these patients can do getting back to play. So patients who had ACL and MCL tears, which coincidentally are the most common combination of multiligamentous knee injuries, had a return to play rate of around 70%, while players who had involvement of their PCL or the posterolateral corner and LCL had a lower rate overall of 55%. Here's another study that looked specifically at young athletes, so athletes less than 23 years old, who underwent surgery for 2 or more ligaments, and they had a mean follow-up of 7.8 years, so pretty good follow-up overall. And they actually found overall in these young athletes a 90% return to sport, but here's the kicker, only 43% return to their pre-injury level. And this kind of gets into really the limitations in using return to sport as an outcome measure for a lot of these studies, because it's kind of a vague category, but it's something that we can do for the purposes of clinical research, to document. But overall, less than 50% return to pre-injury level. Some of the predictive factors on how these players did was whether or not they actually played a cutting and pivoting sport. So you can imagine your knee ligaments are the most under stress in cutting and pivoting type activities. And then also level of sport. And so patients who played at higher levels of sport, whether at the collegiate or professional level, did have an overall higher return to play rate compared to those at lower levels. So for this particular patient, he ended up going to the operating room about 8 weeks or so, 6 weeks I think, after his original injury. We performed a lateral meniscus repair, performed an ACL reconstruction with quad autograft, as well as a double bundle PCL reconstruction. And you can just see a fluoroscopic shot on the right there, just kind of showing the suspensory hardware that he has as a result of this. And he's still actually fairly short out from surgery, so still kind of in that phase 1 of physical therapy where he's protecting his weight bearing. We haven't allowed unrestricted range of motion yet. But at this point, I really kind of wanted to open things up. And let's see, is this okay? Good. I can go back. So at this point, I wanted to kind of open things up to our panel, and I wanted to start with Nina, our physical therapist here, and just ask you, Nina, in your experience, how does the involvement of the PCL or posterolateral corner, I guess you could maybe touch on those separately, affect what you see in terms of overall timeline for rehabilitation, and then what rate of these athletes really return to sport at the same level?
Yeah, so it really slows things down, as you can imagine. So your PCL, if you get it repaired versus if it's non-op, that's going to impact what our movement restrictions are, especially early or post-op. We don't want to have too much hamstring activation early post-op because that's going to tug on the tibia posteriorly and stress that graft. So a lot of these patients, again, have a little bit more strict range of motion and muscle activation in the first 6 weeks. And they also tend to have a different weight-bearing status. And then what I see in particular, just in terms of quad activation, even if the PCL is repaired, there might be a really slight displacement posteriorly, and sometimes it's harder for people to activate their quads, or they end up with a little bit more anterior knee pain while they're activating their quads. And so keeping in mind, in this case, they also had a quad autograft, so that's going to impact that quad activation even more. So ultimately, things that we might see in a single ligament case, or even like an ACL plus an MCL injury, or even ACL plus meniscus, that's going to be a lot faster return to sport than something that involves our PCL. I also would say, I've had a couple multi-ligamentous cases where there's also been nerve involvement. And if there's any sort of nerve or neurovascular involvement, again, that might look really different for what they return back to. And they might not be getting back to that football or whatnot, but getting back to, again, maybe running or doing swimming as a sport. I guess I'll pass this to Hannah to see what she has to say for when these patients get closer to their on-the-field time.
Yeah. I'm interested to hear Hannah's thoughts on that, but I also was going to ask Hannah, as someone who works with young athletes who play football in particular, have you noticed any differences based on position or any other factors like that in terms of who can get back sooner, who has the hardest time after these types of ligamentous knee injuries?
Ooh, that's a loaded question. I do not have football at Urban, thank goodness. But I think I heard someone say it's kind of important to see what the athlete wants to get back to and then the demand on the sport, right? So it is important to think about like their position, if they want to be, we have flag football, so I guess I can try to talk about that. We did have an athlete who had a multi-leg injury, who was a running back and moved to quarterback because it was like less so. And then we had this whole conversation with like the D-line or to like protect your quarterback because he had this old injury. And so there's just a lot of things to think about with that. But really just depends on if the athlete wants to go back to that specific sport or that specific position. And I think I have a lot of conversations with my athletes about what are like short-term goals and long-term goals. And in the high school setting, the season is very short. They don't really have a lot of time. Like you're telling an athlete they're out for like 3 months, and that's kind of their entire season for high school sports. So kind of having that conversation of, okay, we're out this year, but what about next year? And then after high school, what does that look like for you? And so a lot of discussion just on what their identity is in sports at that point.
Thank you. Then my question for Cindy was, as a team physician, that these can be career-ending and certainly career-altering injuries. So how do you have that conversation with players acutely after the injury versus during their rehabilitation process and just kind of, counsel them in that respect?
I think, so one of the things that athletes never want to hear is bad news right away. So the reason I say that is we kind of talked about informed consent, right? And, I have had athletes who have gone in to talk about repair of ligaments, and they're told right away, but your rate of return based on data is going to be this much of a percentage. They don't like to hear that, right? They don't like to hear that. And what they want is they want to go someplace else and go to see a surgeon who's going to tell them great news. I mean, and that is that's just their mentality with the higher level athletes. Okay, now it seems like we're speaking out of both sides of our mouth, right? But I do think that the most important thing is educating them on what exactly they injured and what that ligament or what that body part does. Because they've got to start thinking about how does this injury relate to what I want to come back to do? And you start that process about that, and you start the process in terms of how you're going to manage them short term now. Because surgery, sometimes you have to do it urgently, surgeries, and sometimes you can wait, right? And so depending on what type of surgery you're doing, it depends on how much time you have to let them absorb this trauma that just happened to them. So I seem like I'm going around, Michael, I'm sorry. So I guess in the end, you got to know your patient. You've got to feel them out. You've got to get a sense of where they're at. But education, number one, is key. Number two is if you want it repaired, this is what we're going to do, okay? If they ask you, if they start having probing questions, then they're ready to have the answers. But if they say things like, okay, What's a chance that I can come back, or how soon can I come back? That opens the window too to knowing. Let them ask the question. And I think from them asking the question, you're able to know how much you're going to tell them and in what way you're going to tell them. So if they say, can I come back by the end of the season? Michael's going to say, the surgeon's going to say, or we're going to say, no, you're not going to be able to. But what we'll talk about is next year. What we'll talk about is what we're going to do, like what sports you want to come back to do, and have them start looking forward to that. But I'm no way am going to say, I say, if you're compliant with rehab, if you follow directions, there is a good chance you'll be back to your full activity. I'm not going to give them numbers because people focus on numbers. I will say, too, when you look at the NFL study and the return, in the NFL, they're getting daily rehab. They're getting daily everything. And at the youth athletes, those numbers are a little bit harder to parse because we don't know what their access is to PT and athletic trainers. So it's really hard to look at that return to play and return to prior level competition because they don't have, oftentimes those studies don't say what the rehab is like. Yeah. We all know important. The surgeon is important, their skill set, et cetera, but it's also their rehab, but it's also their compliance. Oh, sorry, I just blabbed.
I also want to say, there's been a lot of talk about physical therapy this weekend, which is great. I'm a PT, I love that. But rehab is hard, and it's really, really hard, especially for our younger aged patients. And if they have a big traumatic multiligamentous injury, and you're thinking they're going to need rehab for 16 months, that just gets long and arduous and challenging. So I think also, having conversations up front, and I do this a lot with my pediatric or younger age athletes about what that looks like, and can we have a little, respite break from PT for maybe 2 months where you're on vacation because it's winter break and you hang out with your family and then come back in hard. So just something to recognize in that return to sport kind of timeline it's long and it's a hard process.
Great, thank you all. So I think we can move on to our third case, and then we can open everything up again to discussion at the end.
We have until 10 till, right? Mm-hmm. Okay. Yeah.
Perfect. This one? I pushed the big green button, you guys. Shocking. All right, so I'm gonna introduce our last case here. I'm a little shorter. So we're gonna talk about low back pain in our female athlete. This is a high school athlete, 16 years old. She has a history of anorexia nervosa, and she was 12 months status post a right ACL repair with a hamstring autograft. Uh-oh. Did I do something? Okay. Oh. Okay, all right, we're good. So she had a mechanism of injury. She was hitting her rehab really hard, which is great. We love that. But she was doing a deadlift with a hex bar, and she felt some pain in her low back. At that time, she had been cleared from her ACL rehab, and she was back to sport. This was a new sport for her. She had started doing crew, going from a team sport athlete to a crew athlete. And so she was in a race, and she was unable to finish the second portion of that regatta due to her low back pain. And she continued to train at that point, but she avoided lifting and erging. These activities that she likes to do outside of her sport is she also likes to surf and swim. And she also reported that her pain was 2 out of 10, localized to the lumbar spine, and she would point right to that spinous process. And she had ags with running, erging, rowing, lifting, and especially with that spinal extension bending backwards. So, what diagnosis are we most concerned about? And I will open this up to our panel. Hannah, if you were, this is one of your high school athletes. She's telling you this in the training room. What are some things that are concerning to you? And yeah.
Yeah, I think the first thing that's concerning to me is the sensitivity to being in that extended position. And so the first thing I would think about is spondy. It would be in my diagnosis for sure. I've also, for some reason, had a few spondies this year in the high school setting. And so it is something that I am very heightened to.
Yeah, agree with Hannah. Spondy is spondylitis or a stress fracture in the posterior pars interarticularis of the spine of the vertebrae is what that refers to. Certainly someone who's had a history of anorexia nervosa, which is kind of great that that was disclosed. And oftentimes, though, people aren't going to disclose that. And so if you have a high index of suspicion for a stress fracture, those are the types of questions you start to ask, like, what's your diet like? Again, knowing your athlete, soft questions initially. If you ask right away, like, have you had an eating disorder? They may clam up, especially if they're embarrassed about it, because a lot of people are. So really getting that out, but certainly knowing that they have a history of an eating disorder puts that index of suspicion higher for a stress fracture.
I completely agree. And it's both the history of the eating disorder and also, the athletic activities here as well. So the repetitive motions involved in participating in crew as well would certainly put her at risk for that with the repetitive extension. So yeah, that's what I would be worried about too.
And if we look at what was examined with this patient, our panel was spot on. Well done, panel. So things that we want to consider are bone health, right? Like this patient did disclose that she had had a disordered eating, and what does her DEXA look like? What does her bone health look like? I think also, to keep in mind, she does have a past surgical history, and she had a really robust return post ACL. But she was doing a different sport and then switched sports. Unclear what the motivation for that was, but some of the lifts that she was doing maybe were initiated in that rehab plan. The second thing to keep in mind, or third thing to keep in mind, is that she also was hypermobile. I used a Baton score, which is just a general screening for connective tissue hypermobility that looks at a couple of different conditions. Ultimately, she doesn't fall crazy high into that category, but she did have a ton of spinal extension, flexion, and then she had, hyperextension at her elbows and at her knees as well. And so she was just overall a little bit less stable in her spine than we would like to see. And then the last thing that I think really we've touched on is kind of a biomechanical sport demand. So if we think of something like rowing and a new rower, I don't know, how many people here have done crew or used an erg machine? Because I am not a crew athlete and I have used an erg machine, and I must say that I think it is a very hard sport to have good form with. It's also a really repetitive sport. We think a lot about running as a repetitive sport, but crew is a very repetitive motion that you have. And then on top of that, they're even selected like to a boat side, right? So you might be seeing somebody that's only on the left side of the boat. And that plays a huge part in what we're looking at, because this patient is going into that repetitive extension all the time. And although that's not the mechanism of injury, that can certainly play a part in maybe why she was more fatigued when she went into the lift or whatnot. So what was found, this is an image we have an x-ray and then we have an MRI. And I wish I had a pointer because these arrows are slightly off, but if we look, there's some lucency in the bone right at that pars, but there's not a discrete fracture. So this isn't necessarily our typical spondylolysis. This is more of like bony edema into that area. And we had a really good conversation about this earlier, and Dr. Cheng pointed out that we would classify it as a spondylolysis because we need to be able to code it somehow. If you also look at the DEXA results are pretty good. So there's nothing that stands out from like a bone health injury or issue, but it was nice because we were able to screen that as well. So the big question is, what does our return to sport management look like? And does it change now that this isn't like an acute pars fracture and it's more of that bony edema? So I will first open this up to our panel, maybe if Hannah wants to start us off, or?
All right, let's see. So for acute management, I would definitely take them out of their sport. Bracing is really important, getting them out of that hyperextended position is going to be really important as well. And also just, with being an athletic trainer, I'm also just waiting for their surgeon or their doctor to kind of tell me what their orders are, just so that I can also follow that through. But for someone with a chronic spondy, it's a lot of activity limitation, but also what can you do, and then every single day trying a little bit more and pushing it, but not pushing it too much. Because at that point, being in a chronic place is more so getting that movement, flexibility, general health, what are their goals, what do they want to get back to. But as far as acute management goes, definitely very conservative is what I typically tend to go towards.
I think the important thing, and Hannah kind of talked about it, for a chronic spondylolysis is that you've made that diagnosis and there's going to be no healing. So what happened, and they may know they have a chronic, but what happened was at some point, we can get to there's all kinds. So let's just say this is a sports-related, and it started from a fracture or edema, and it never healed. It went to a non-union, okay? And this has become chronic. So this is not going to heal, but they have a recurrent back pain because they're in a sport or activity level. So exactly what Hannah says, right? It's not going to heal. So whether or not you use a brace or not, they dependent on their pain level. So if they're having pain with sitting, pain in class, pain with walking, pain with sleeping, we would talk to them about bracing, okay? And then we get into still do your rehab. You can take the brace off to do rehab, but essentially you're going to get stronger. So let's switch to acute. So this is an example of an acute spondylolysis, if you want to lengthen it out. Whether or not it's edema or acute fracture, it's acute, okay? In that case, the same thing goes. What I will talk to my patients about is if they have, again, pain with sitting, pain with working, pain with walking, pain with sleeping, we'll talk about short-term bracing, because I think Nina's going to talk a little bit about the data in terms of does a brace for 3 months, which is how I was trained decades ago. That's what we were trained. But it doesn't really, those healing rates are not great. So we brace them, I brace them for symptomatic, and they start their rehab, they start their strengthening right away. And their return to sport, though, is dependent on how strong they are and if they're ready to go back to their sport. And Nina can talk about that.
Yeah, I mean, I would just say this is a scenario where I greatly appreciate the input of my athletic trainer and physical therapy colleagues, because it really is kind of a nuanced balance here between, a reduction in activity, but also training of the core muscles and everything else that is actually going to help this problem get better in a non-operative way.
Sorry, I don't like standing behind this podium, so. So if we look to the literature about what it says, that acute management is really when these patients get braced, but there's not a lot of literature on how we run our rehab plan and how we get them back to sport. As Dr. Chang said, this is really a condition where people are in a brace to tell them that they should limit their activity. That's kind of how I go through it with my patients, right? I want you out of the brace when we're doing PT exercises, but the brace is really there, so especially in our younger populations, they don't do something that would injure it again. And it's really symptom driven. And most of the time our rehab plan is going to start in like a neutral spine position and then progress, over time to extension. And extension is going to be that kind of last piece that we integrate in. And as anyone that was here earlier for the female athlete case, you heard, how important core and glute musculature is. And the same applies in this case as well. So really our rehab plan focused heavily on getting her additional core stability. She really liked to kind of, for lack of a better term, like booty pop and hold. She was in this lordotic position a lot. So it was about training her to kind of tuck a little bit. And if we tested her with spine extension, her glutes were really, really strong. But if you got her out of that spinally extended position, she wasn't as strong. And so that's where we started our rehab plan. And that's kind of where the literature goes. Although, again, this isn't an area where there's a lot of robust literature on how to pace or plan our rehab around it. I think, one thing that was really important in my considerations for return to sport is where she was at with her disordered eating and if she fell into a red spectrum. And looking at some of the International Olympic Committee ideas, like she wasn't in any sort of risk factor to not compete. So she had seen a nutritionist and a dietitian. She was being managed on that end. She now had a regular period again, and she wasn't complaining of fatigue or anything like that. So she was working really hard on that fact. And then the next piece that we looked at is kind of pain-free progression with sport-specific activity. So it is really hard to replicate erging or rowing in a PT clinic. That being said, we did a lot of periscapular strengthening work with her because, again, she loved to go into that hyperextensive moment. And so we were thinking about how we work on power from our legs and how we work on sort of, again, mid-trap, low-trap, to make sure that she has a right rowing form. And then I'm not a rowing coach, so we collaborated with her coaching staff to make sure that as she was pacing herself back, she had good form with that. And we used a 25% increase in work per week to pace her back to sport. And ultimately, a spoiler alert, she did really well. She got fully back to rowing, and she's actually going next year on to an East Coast school to row in college. So a success story there. But I wanted to just ask our panel. They have ideas.
I just wanted to emphasize the importance of technique because in U.S. rowing, we don't see spondies. But these are elite athletes, right? They know how to row. And if you look even there on the erg, there's no extension, right? There's no really extension. Now, once they're on the boat, once they're on the water, then they've got the element of rotation, that adds into it as well. But when you're strong, it doesn't happen in your highly elite athletes. But in youth athletes that are learning how to row, this is a new rower. This is the problem. And there's so many people out there, and the coaches can't. The ratio is pretty high. So this is the issue, right? Is getting back because it doesn't help that they're going to return and be healed if they're going to go back to the same crappy form. So that really has to be keenly emphasized.
I think the other thing I didn't mention is training years. So, she was newer at this sport, and that's something to keep in mind for load. Is she kind of jumped full both feet into this sport because she was really excited to get back from her ACL, and she didn't have a lot of training years of experience. So that will affect her tissue's capacity to load in a specific way.
We can take like a couple. Yeah, maybe two. Any questions from the audience? We have a couple. Well, we're kind of at time, but we have a 10-minute break in between, so we can hustle. Great. I will. Yes.
Back to the sickle cell athlete, and this is just what I just don't know. When you have splenomegaly, do you also have an increase in friability?
Splenomegaly, so you're talking histologically, is there an increase in friability of the spleen with
yes.
the splenomegaly? I don't think that, unlike infectious mononucleosis where they looked at that, I don't think that there's that inflammatory component. It's a very different reason for the splenomegaly as opposed to an infectious reason for it. But I haven't seen any studies on that. If anyone has, let me know. But it's enlarged because the infarction part of it and the edema because of that.
I guess I had a related question to that as well, which is far outside my knowledge as an orthopedic surgeon, or at least things that I wish I remembered better from medical school. But with hemoglobin SC in particular, do you know, are those patients considered functionally asplenic? So in other words, the splenectomy may not actually be making a huge difference in the risk that they are already at in terms of those infections and other things. Because I guess that would change my counseling of this patient of whether or not it's a good idea to have, a splenectomy or not in that football season if they're already going to need those additional vaccinations, antibiotic prophylaxis, everything else.
So it's a spectrum because it's variable in the disease presentation. So because of the fact that he had splenomegaly and the fact that most of the SCs don't have auto splenectomies, that they are not functionally asplenic. But if they've had a lot of crises, that he certainly, or anyone with SC certainly could be asplenic. But I think that is certainly something that you can test and evaluate depending again, he presented at 14, but had never been hospitalized, had never needed transfusion, so he had a mild case relatively, except that every time he went into altitude, or cold water, this is what happened. And we have athletes that won't play at high altitude. We have a new team in Denver, we NWSL, right? So we have a new team in Denver, and we have NFL players. We know of NFL players who won't play when they go to Denver, Mile High Stadium, because of their history with sickle cell trait, those with sickle cell trait. So you just have to, knowledge is power. Knowledge is power in terms of knowing what you, and this young man, we all felt really good, the athletic trainer and I felt really good about it because he had knowledge, more knowledge than he had been given up to the age of 14. And he had more knowledge now that he could control and know what his risk was. And that's why he pulled himself out of hot weather days for practices.
All right. Well, thanks, everybody. Thanks for the great questions and the engagement. Let's give our panel a big round of applause. Thanks to the panel. You guys are awesome. And we will reconvene at 3 o'clock.